Right. Hello, everyone. Now we're going to look at the anatomy for the module 8, the last of our modules. This is the lower limb part 2. So let's go ahead and look at deeper muscles in the lower limb. So before we even go deeper, we're going to look at the different structures of the pelvis. We already looked at from the first part of the lower limb. We looked at the ilium, that's the ilium bone, and then we have the ischium and the pubis. Remember, all these three bones make up the hip bone, the coxal bone, right? And then here we have the coxofemoral joint, where the head of the femur will articulate here. Remember the ball and socket joint. So the head of the femur is going to articulate with the acetabulum right there. So we already looked at a few structures in the first part of the lower limbs. We look at the ASIS, the anterior superior iliac spine. And as we go lower here, remember we go 2 fingers down, 2 fingers inferior, and then 2 fingers medial. That will lead us directly into the anterior inferior iliac spine. So AIIS, so different structures will attach onto that. So just a reminder from the ASIS, 2 fingers down inferior and then 2 fingers medial will bring you to an estimate of the AIIS. And then you have the iliac crest. Remember, we can divide it into sections. It could be the anterior part of the iliac crest, and then we have the middle part and then the posterior part, if it's divided into 1/3. So that would be the iliac crest. As we go in a little bit more into the fossa, that's the gluteal fossa on the posterior end, and on the other side, it would be the iliac fossa. Okay. So those are the main ones we look at for the ilium. So we're going to look at a few more deeper structures today. Here we have the anterior gluteal line. Okay, so from the gluteal fossa, and then here it would be anterior gluteal line. And then if we go a little bit lower here, we have the inferior gluteal line. So go ahead and circle those structures. So we have the inferior gluteal line, the anterior, here we have the inferior gluteal line, and here we have the posterior gluteal line. So different lines and structures there. Then let's go ahead and look at that ischium. We already looked at the ischial tuberosity, where the hamstrings are attached, the origin of that. We'll look at the ischial spine today. So if we go right above, more superior, you'll find the ischial spine. And here we have the body of that ischium right there. And then we have right in the front on the anterior part, the pubis. So that pointy part, the pubic tubercle. Remember, there is a pubic symphysis, a cartilage between each of them that joins the 2 pubis together, that also joins the 2 hip bones together. That's the cartilage, the pubic symphysis, the abdomen, the rectus abdominis will attach onto that symphysis. Okay. And then the pubic tubercle here, and then we have the ramus, the pubic ramus, you have the inferior, and you have a superior part, you have an inferior part. And then you have this hole right here. Remember, the hole in Latin is foramen, so obturator foramen. So anytime you see a foramen, you'll probably notice that there's a lot of arteries, nerves, spinal cord that's going to come in and out of. So those are what foramens are usually for nerves, arteries, veins, the spinal cord. Okay, so here we have the obturator foramen that's there. Okay, I think that's about it for what we're going to cover. Here, just another reminder of the sacrum. We're going to look more at the lower limb hip part. So just to get familiarized with that sacrum area, remember it's a kyphotic kyphosis here because it comes outwards. It's fused bones, S1, S2, S3, S4 fused together to form one solid structure right there. And then you have the coccyx, that's right there. Okay, also fused bones together, the tailbone. Here you can see more of a posterior view. Here's more of an anterior view. Here you get the posterior view right here. Okay. And then the coccyx. All right, and then we look at the femur. You have the head of the femur, and then you have the neck of the femur, and then you have the whole shaft here of the femur. Here you can see, remember the greater trochanter on the side of our hip, that big bump right there, where we have the gluteus medius. We'll touch onto that. So the side here. And then today we're going to look at the lesser trochanter. Lesser trochanter is like on the inside of that. So it's less palpable, it's pretty deep, but it's on the inside. We're going to look at that because the psoas muscles are going to attach onto the lesser trochanter. And then in between there, you can see there's the intertrochantic line in between. So if you look at it, it really reminds us of the humerus. Remember, the humerus has a greater tubercle and lesser tuber and intertuberous sulcus. Here we have the greater trochanter, lesser trochanter, and intertrochantic line right there in between. And then we have the shaft as we come in a little bit lower. On the posterior side of the femur, there is that line. Remember the linea aspera. The linea aspera goes along there. And then we have the glute maximus is going to attach onto the superior part of that linea aspera, and then the hamstrings, the biceps femoris, more the there's two heads. Okay, so the long head will touch more on the ischial tuberosity, and the short head will attach onto the inferior part of that linea aspera right there. So it's a line that is on the posterior side. Remember the quads, the vastus medialis and lateralis will come attach onto that from the posterior side and wrap towards the front, towards the knee, on the different insertions of the knee. Okay, so the linea aspera does take a lot of insertions and origin points right there. So it's in the back. Just make sure that you understand it's in the back of that, the femur. And then as you go more to the distal part, you have two bumps. You have the lateral and medial condyles. So also if we go epicondyle would be the tips of that. All right, then you have the, as we go lower, we have the patella. Remember, it's a sesamoid bone. We have the base of the patella, and then here would be the point, would be the apex of the patella. And then as we go down to the anterior part right here, right mid part, you have the tibia. So the tibia also have epicondyles, lateral and medial epicondyles on each side. And then here right in the middle, if you go from the patella, go straight from the patella going down, you have the tibial tuberosity. So the best way to find the medial and lateral condyles or epicondyles of the tibia is to find the tibial tuberosity and go to each of the ends right here and find for the bumps. That's the easiest landmark to find. And then you have the shaft, all right? So in the first part of the anatomy, we said more of the tibia, the shaft here. But because we're looking at deeper muscles and we're going to have muscles in the back that's going to be attached, so just we're going to change our perspective a little bit. We're going to say this is the anterior part of the tibia, and then we notice on the back would be posterior part of the tibia, and then if it's more towards midline, this would be the medial part of the tibia, and of course this would be the lateral part of the tibia. Okay. And then as we come more and more to the distal part, it forms the medial malleolus, the inside of the ankle. And then the fibula here, the head of the fibula. So another way we can find the head of the fibula is from the tibial tuberosity, go to the lateral, find the lateral epicondyle, and then go slightly on an angle downwards inferiorly, you'll find the head of the fibula. It's pretty prominent point right there. And here you have the shaft of the fibula, and then at the end, you'll find the lateral malleolus, the outside of the ankle. So same thing, we want to consider the anterior part of the fibula. On the back would be the posterior. On the inside here would be the medial part, and on the outside here would be the lateral. So it's not indicated here, but remember there is an interosseous membrane in between these two bones to keep those two bones together. So it's a fascia connective tissue, a membrane. Right? And some muscles can be attached onto the interosseous membrane, as we already saw in the first part of the lower limb module. Okay, and then we go to see the foot. So we have the calcaneus, which is more the heel. So this is a top view or dorsal view, we call it. So the calcaneus is that heel bone. And then the talus is right on top right here. Remember, the ankle joint is the talus, the fibula, and the tibia. Those three bones form the ankle joint. And then here you have, if we go more on the medial aspect right here, let's go on the medial aspect. Here you have the torso bones, you have the navicular. So just think about like a navy bean that forms a navy. That's how it gets its name, a navicular bone. And then right distal to that, you have the cuneiform. So you have the first cuneiform, second cuneiform, or third cuneiform. You might even see medial cuneiform, middle cuneiform, or lateral cuneiform. That is possible too. And then right on the lateral end, you find a cube shape. That is the cuboid. Okay, so we're going to look at attachments today with these certain bones. And then we have as we go into the metatarsals. Remember the metatarsals, these are long bones. So there's a base. So there's a base right here. There's a shaft and there's a head. So if we're talking about this one, the big toe areas, this would be the first metatarsal base, second metatarsal base, third, fourth, and fifth. So there's the metatarsals as we come into the phalanges, still long bones. So the big toe has the distal and proximal. Proximal closest to the heart, distal further away. And you can see here, second, third, fourth, and fifth has a proximal, middle, and a distal part. Okay, so those are the different bones of the foot. Now let's look at the joint. So that's the coxofemoral joint, the head of the femur will articulate in the acetabulum, allowing for the ball and socket joint. There are a lot of ligaments are also to prevent you from going to too much of those certain actions. And then the knee joint is a hinge joint. Remember, the femur and the tibia will articulate during that flexion extension. And though there will be different ligaments preventing you from going too far or rotation, too much rotation of that. That's why it's more of a hinge joint where the coxofemoral joint will allow more free range at the hip level. And then the ankle joint, here you have the fibula, tibia, and the talus that allows for more also plantar flexion and dorsiflexion. Okay, and slight movement, abduction, adduction. So very slight. Okay, so if you want more of a movement, it's going to go up towards the hip to allow the movement of more of that rotation. But it's more of that plantar flexion, dorsiflexion. So pointing your toes away, pointing your toes towards you, that will be more the main actions of that ankle joint because it's at this level here. And then you have all the different toes, the phalanges. These are all different hinge joints, right? Because it allows only flexion extension. So we're not going to go into detail, but just to know that there are joints in each of the toes, each of the metatarsals. All right, so just a little review. We already looked at most of the actions. So hip action, flexion towards the front of the body, extension towards the back. Remember, the leg is straight with the knees not bent here. We're looking at the coxofemoral area. Internal rotation, rotating inwards, external rotation outwards, adduction going towards midline, abduction away from midline. And of course, circumduction is a combination of all these actions together. Then we have pelvis. The pelvis starts to tilt as the ASIS, so the pelvic anteversion. Imagine the ASIS tilting forward, retroversion, ASIS tilting backwards now. So just imagine anteversion, your butt sticks out, and then retroversion, your butt sticks in, going backwards. So think about what muscles are involved. We talked about a little bit about from last module in our treatment plan about the QL, of how QL is more of a pelvic muscle opposed to more of a back muscle. Even though it's located in the back, in the low back, it doesn't do trunk extension, it does more of a retro anteversion, right? And then knee flexion extension. Okay, so knee flexion, bending the knee, extension, straightening the knee, ankle inversion. Think about the bottom of the foot pointing towards the inside, the medial side, ankle eversion, the bottom foot pointing towards outside. Plantar flexion is pointing your toes away from you, and then dorsiflexion, bringing your toes towards you. And then pronation, supination, we don't look at so much as main actions, but if we do, you might see it in how people walk, how they run. Pronation, their ankles will probably go towards the inside, and then supination is going towards the outside. Okay. And then toe flexion, we're bending our toes, flexing our toes, extension, spreading our toes, and then abduction, away from midline, and adduction towards midline. So let's look at some photos just to bring that to the action. So flexion, you can see here, bringing towards front, extension towards the back, abduction away from midline, adduction going towards midline here. Lateral rotation or external rotation, remember it's at the coxofemoral joint, so it's bringing outward. So here is what I was saying, the foot that turns outward, it's the hip that's doing it. It's not the ankle. The ankle cannot do that. After a certain degree, it's going to go up to the hip to create more of that rotation. So even you see the foot is moving, it's actually at the level of the hip that's doing that. So that's a lateral rotation. Rotation right there. Here's an image of that pelvic anteversion. So this is the anterior part. Remember, the ASIS is tilting forward, and then all this is tilting backwards. So everything here. So that allows the butt here, the glutes, to stick out as we're doing an anteversion. And then retroversion, here you can see the ASIS is coming up and backwards and tucking in that tailbone. See here, you can see the sacrum pushing out. And then here, the sacrum is tucking in. So that's retroversion. Here you can see an anterior tilt, posterior tilt. You might see it as that. Okay, same thing. And then you have pelvic elevation. Hips are moving upwards. So you remember the QL, the quadratus lumborum. We'll do a pelvic elevation also. Okay, so you might have clients that says, I have one leg shorter than the other. So you want to verify the hips. Is it really their femur or their leg that is actually shorter than the other, or they're giving the illusion because of an imbalance in the hip, giving them the illusion of that. So most of the time that can be the problem because of a postural issue. So here's a pelvic lateral tilt happening here. And then knee action, we have knee flexion. Here you can see the person bending the knee, and then extension, straightening the knee. Okay, so you want to look at the hinge joint. And then ankle, more of a dorsiflexion, plantar flexion. It also turns slightly into inversion, eversion. So those are the main ankle actions we'll see. So remember, inversion will be going the bottom of the foot turning towards the midline inside, and then eversion turn towards the outside. And here we have pronation. It's more of a postural than more of an action. So pronation is where they lean more inside. This is normal. And then here you supinate it, lean more outside. Okay, a good way to even see if this person is how they're distributing weight is looking at their shoes. Is it more worn out on the inside or more worn out on the outside? Here are the toe actions. We're not going to go too much in detail in the toe actions, but just to see. So flexion going towards C, and here flexing, and then extension going towards yourself. and abduction away from midline, and an abduction going toward midline. Okay, so we'll look at some lower limb muscles just to quickly review, because we are looking at deeper ones, so it's good to always see what muscles are on top. So here we go. So glute maximus and glute medius. The glute maximus, the big teardrop muscle right here, most superficial, big, huge muscle. Remember we said the glute maximus is helping us climb stairs because it's going to help lift up that hip. Opposed to glute medius, it's more of a hip stabilizer, more in walking. Okay, so let's say if we're comparing two different athletes, glute medius will be more marathon runners because of that long distance, they need to stabilize the hip more. So they will have more glute medius issues, opposed to someone that does short distance and running with hurdlers, track and field, they will have more glute maximus because of that lifting action there. So that's very important to see. So glute maximus, you can see here, attaches onto that sacrum, the iliac crest, posterior part, and then the linea aspera, more on the superior portion, and then that creates the teardrop, and it attaches onto that connective tissue, the ITT, the superior 1/3 of that. And then the glute medius will have an attachment more on the medial part of that iliac crest and insert in that greater trochanter. So just looking at the fiber orientation, the glute medius will do more of a hip abduction, right? More of the, but its main thing is the hip stabilizer. Where the glute maximus is a huge muscle, it can do several kind of actions. Right? If we bring the insertion closer to the origin, it can do hip extension. It's in the back, so automatically we'll look at hip extension. It's a big external rotator, external rotation of the hip. It also is a big hip abduction. So when you hear the words hip rotator, external rotator, hip abductor, you might want to look at the glute maximus. Extensor, hip extensor, that's a huge glute maximus. What else? Hip abduction. Yeah, those are the main things that the glute maximus will do. And then you have the hamstrings. Remember, hamstrings, common origin is at the ischial tuberosity or sit bones right here. The biceps femoris, two heads, a long head and a short head. If you go ahead and bend the knee, you can feel the tendons really at the knee fold there. So on the lateral aspect here, it will attach at the head of that fibula and the lateral epicondyle of the femur. I'm sorry, of the tibia. Okay. So it has an attachment there. So you can see it's at the linea aspera, one inferior, one half here. So biceps, you have the superior part and you have the inferior, the long head and the short head. Here it's on the lateral aspect, and then the semitendinosus and membranosus is on the medial aspects. The membranosus is underneath and the tendinosus is on top. The membranosus is going to attach on more on the medial aspect of that. The tibia right there, there's a tendon right there, and then the tendinosus is going to be at the medial epicondyle of the tibia, so at the pes anserinus. So they work as a group, right? And they could either have a hip action, so hip extension, or knee flexion. So just the fiber orientation goes up and down. It's rare that it's going to do a rotation just based on its fiber orientation. It's going to do mostly a hip extension, right, based on whatever muscles attach onto that hip. So just as a reminder, the short head does not attach at the ischial tuberosity. So the short head will only be has an action of the knee, which is a knee extension, but all the rest will have a hip extension and knee extension. Sorry, not knee extension, knee flexion. We have knee flexion. So hip extension and knee flexion. Okay. All right. And then we have the quadratus, the quadriceps. Quadriceps, there are 4 of them. The rectus femoris, that goes straight down the middle from the ASIS. All of them will have a similar attachment at the base of the patella, at the tibial tuberosity, and through an infrapatellar tendon right across the patella right there. Okay, so go straight. This is the rectus femoris, straight on the femur, goes straight up and down right there. So it's mostly going to do more of a hip action, right? Hip flexion because it's in the front, and because it touches on the knee, it's going to do a knee extension. Okay, so just to clarify, the hamstrings will do a knee flexion, and then quadricep will do a knee extension because as we're straightening the knee is coming closer to the hip right there. Then we have vastus medialis and vastus lateralis that is attached onto the back of that linea aspera and comes and wraps towards the front. And then underneath the rectus femoris, there's intermedius, attaches onto the anterior part of that femur. So remember, look at this, the vastus medialis and lateralis and intermedius does not cross the hip. It doesn't have attachment onto the hip. Therefore, the vastus, all 3 will have more of a knee action, so knee extension, where the rectus can't be. So if someone is having problems with their quads, you want to do the actions that's happening at the hip, or you want to do an action at the knees to very distinguish where the problem is coming from. Then you have the sartorius. Sartorius is that seatbelt muscle that crosses over the quads. So from the ASIS crosses to the inside of the knee through the medial epicondyle of the tibia, also the pes anserinus. Remember the pes anserinus tendon, you have the sartorius, the gracilis from the adductors, and the semitendinosus from the hamstrings. Okay, so from there, you have the hip adductors. Okay, we look at it as more as a group muscle. Okay, most of it will attach onto that linea aspera also. Okay. Here, as you can see, the gracilis comes and attaches onto that medial epicondyle. So it'll do hip adduction, bringing the hip inwards. Okay, where sartorius, you can see it does more of a hip flexion, front here, and also external rotation. Okay, then we look at ITT and TFL. ITT is a connective tissue, so there's no specific action towards it. It's all connective tissue. You can see the glute maximus attaches onto the 1/3, and then you have the TFL here, tensor fascia lata, will attach also onto that 1/3 more in the anterior. So the glute maximus and the TFL are antagonist muscles. So this is a muscle that tends to get very tight, TFL, for any kind of hip flexion problems. Attaches on ASIS and then into that 1/3 of the ITT. At the ITT will attach on the medial crust, and then down the lateral part of the leg into the lateral epicondyl of the tibia and the head of the fibula. And then the gastrocnemius, our calf muscle. Okay, so it attaches above the knee into that supracondylar line of the femur. Remember, there's 2 heads. There's a lateral and medial head, and halfway through this all tendon. This is called the Achilles tendon. Achilles tendon, it's going to attach onto that the calcaneus, the heel bone. So that is. So there's a knee flexion, has a knee action. Also, it has an ankle action because it attaches onto that calcaneus. So it'll do plantar flexion, pointing our toes away from us. So that's going to contract that gastrocnemius. So that's the most superficial part right there. And then tibialis anterior on the front, on the anterior part. See how it crosses. So from the lateral epicondyle of that tibia crosses over to the front of the tibia. It's going to anchor onto the anterior bone right there. And then you can see it's all tendon, and then goes under into the first cuneiform and the first metatarsal base right underneath. So this one will do more dorsiflexion, pointing our toes, towards us, dorsiflexion. Okay. It also will do a inversion, bringing the bottom of the foot inwards. So bringing this tendon closer to the origin right here. And then right on the lateral side, we have the peroneus longus. We'll look at the brevis later, but for now, the longus, you see at the head of the fibula, going attaching onto the shaft of that fibula. And here you can see tendon again under the ankle, under the lateral malleolus, and then again joining the same of where the tibialis anterior is, the first cuneiform and first metatarsal base. Okay, so this one will actually do more plantar flexion, okay, just based on where the origin insertion is. So the peroneus longus and gastrocnemius would be synergist muscles, and then the peroneus longus and the tibialis anterior would be antagonist muscles. This will also do an eversion, pointing the bottom of the foot outwards. All right, so let's look at some newer muscles today for now, for this module at least. So here we have the psoas. The iliopsoas is a group of the psoas muscle and the iliacus. This is what we call our deep hip flexor muscles. These are the only muscles that attaches from the upper body to the lower body, to that lesser trochanter right there. Okay, so you can see this is an anterior. It can be pulling on that vertebrae. So on the anterior part of that vertebrae, and then into the under that inguinal ligament. So let's look at it individually. So the iliacus. So if you want to even palpate on your iliac crest, and then if you sink your thumb inwards, there's a very tight spot. You probably get into that area. This area tends to get very tight because we sit a lot, right? People that sit a lot of runners might get psoas issues because of that tight. But yeah, a lot of my clients who sit tend to have tight psoas muscle because of that closed chain muscle here. Okay, so you can feel that structure there, being very tight, iliacus. So origin is at the iliac fossa. That's on the anterior part of that ilium. So all that is the iliac fossa. And then you can see it goes under and then into the lesser trochanter. It's on the inside of that. So the great trochanter is on the outside, and then right on the inside here is that little bump of lesser trochanter. So by bringing this closer to the origin, that will bring more of a hip flexion as the main action. It also will do slightly external rotation of the hip and hip adduction, but it's main when you hear deep flexor, hip flexor muscle, you're probably talking about more of the iliopsoas group, iliacus and psoas. Then we look at the psoas major. Psoas major, it attaches onto T12 to L5 on the anterior part, and then also on the transverse process. And here it goes into the lesser trochanter. Okay, so you can see that having hip issue can create a slight lordosis in the lower back. All right, so if you want to really investigate when someone do have low back pain, we looked at QL as a possibility, quadratus lumborum. Psoas major now is something that you might want to consider. We also looked at diaphragm. Diaphragm is also attached onto onto the vertebrae, the lower lumbar vertebrae. So you want to look at what might be causing it. Is it breathing? Is it postural? Is it a hip flexor? All those can cause low back pain. So the psoas major, main action is hip flexion, external rotation of the hip, and hip adduction, same as the iliacus. So creating this group of muscle right there. So stretching it with doing lunges, bringing it away, bringing it more into hip extension will be some examples of stretching the psoas muscle. Okay. Okay, then we look at gluteus minimus. So there's another layer now from glute maximus, where if we take the cut of the glute maximus, and then we cut the glute medius, right underneath, we have the gluteus minimus. So it attaches onto the anterior and inferior, so in between the anterior and inferior gluteal lines. And it's going to insert onto the greater trochanter, but more on the anterior part. So because of that, so the main thing it'll do is hip abduction, same as the glute medius. But because it turns a little bit, where the glute medius just goes straight to the greater trochanter, here goes to the anterior portion, it's going to do slightly internal rotation of the hip. And because it's slightly anterior, it'll have assist in a little hip flexion. Okay, so it's, as we look at deeper muscle, we know that it's going to be more stabilizing. We already know that glute medius stabilizes the hip. So glute medius even more of a stabilization in the hip area right there. Okay. Okay. So as we go even deeper now, we have the external rotator muscles right there. So we have the glute maximus, that is the most superficial, glute medius right there, also superficial. Right under the glute medius, you have the glute minimus. And then you have a fan of different muscles. So the piriformis, and then you have the gemellus superior and inferior, and then the obturator externus and internus, and then you have the quadratus femoris. Here you can see the sciatic nerve. Okay, we talked about sciatic nerve, of how it can sense shooting pain. So remember, when it's false sciatica, it's a compression of that sciatic nerve. If it's true sciatica, that means they have a herniated disc. So false sciatica can have a compression of this. So piriformis is a muscle that can be compressing on that sciatic nerve. Also, quadratus femoris can be a possibility that can have an effect. But the main thing you can see here, the piriformis, will have a compression on the sciatic nerve right there. So let's look at these muscles as a group, individually, and then as a group. So here the piriformis. So the piriformis, it attaches onto the sacrum, but more on the anterior part. So not on the posterior, it's really on the anterior portion right here. And yeah, I recommend really palpating these muscles. So from that piriformis, and then going towards the greater trochanter, or more on the posterior side. Okay, so right there would be the piriformis. So when you are working with the piriformis and there is sciatic nerve, you wouldn't want to go directly on it because you're compressing the sciatic nerve even more. A trick you can do is going on top of the greater trochanter, bring your fingers in, and then releasing the muscle from behind. So you're not creating more compression on that side nerve. So just a little being more mindful of that, because if not, you're just creating more pain, more shooting pain. We don't want to create that. So going from the back door a little bit. Okay. So the piriformis, it does external rotation. Okay, same as the other groups. But here's something very interesting. When your hip is flexed, so imagine if you're doing the pigeon pose. If you don't know what the pigeon pose, look it up, what a pigeon pose is. When you go to a yoga class, let's do a pigeon pose, and that's going to stretch the piriformis. But it's like, wait a minute, but it's doing an internal rotation. right? I'm supposed, when we're stretching, it's supposed to bring insertion and in origin insertion further away. So what happens is when the hip is flexed like pigeon pose, you change the chain, the closed chain. So now it becomes a hip internal rotator. So that's why when you're doing the pigeon, you're doing external rotation to stretch it. If you have your leg just straight, it does a external rotation. You're doing internal rotation to stretch it, right? But because you're in a closed chain now, it becomes an internal rotator and you're doing external rotation to stretch it. Okay, so try it out to really understand it. So let me just clarify that. So when we're in closed chain as hip flexion, the piriformis becomes a hip internal rotator. It does, and it also does a hip abduction. Okay, when the hip is flexed. Okay, it's in your notes of the chart there. So just keep that in mind when you're doing piriformis. That's what's happening. If the leg is straight, then you're stretching it, you're doing internal rotation because the piriformis is an external rotator. Okay, just to create more confusion, but it's quite interesting. All right, so let's look at the gemellus superior. Gemellus means twins, so you have a gemellus superior and a gemellus inferior. So gemellus superior, you have at the ischial spine right here, and then into the greater trochanter on superior surface. And then right here, just going a little bit more lower onto the ischial tuberosity, but more on a lateral aspect, more a little bit higher than where the hamstrings are. And then it also attaches on the superior surface here. So right next to it. So you have the piriformis and right under gemellus superior, gemellus inferior. And also these two will do external rotation of the hip. They're all external rotators. And then you have the obturator internus. Obturator internus, remember the whole obturator foramen, it's going to attach onto a membrane. So obturator membrane and the inferior surface, on the inferior surface of the obturator foramen. And then it's going to attach again onto that greater trochanter, but more on the medial side now. Medial side. So it's going to touch on different parts of the greater trochanter. But easiest, just look at it as more of a general overview of the greater trochanter. Okay. So that's the internus, and then the externus we'll have at the pubis area, the pubis superior and inferior ramus. Okay, so the ramus. So here you have the pubis. So the inferior and superior ramus, that curve right there, and it's going to come insert into the trochanteric fossa of the femur. So it's really inside or inside of that greater trochanter right there. So it will do more of an external rotation also. So this is a deeper muscle right there. And then quadratus femoris into that ischial tuberosity on the more lateral border. And then here into the intertrochanteric crest. So that's between the lesser and greater trochanter, intertrochanteric area. Okay, so you can see that the quadratus femoris is really that square shape. It's one of the hip stabilizer. It's a big hip stabilizer muscle also. So if you have clients that have very weak hips that you want to look at glute medius, glute minimus, the quadratus femoris. So this is the only muscle out of the external rotator that does pure external rotation, right? Where the other ones can change based on that hip flexion because of its curvature. Here, it doesn't allow much of that movement because of its shape. So it just stabilizes the hip. It stops it from creating moves. So the other ones will do more when the hip is flexed. It'll do more the change of the action there, like the piriformis. Okay, so the quadratus femoris will do strictly purely external rotation. okay? This can, quadratus hip muscles can cause a lot of hip issues, okay? External rotator, TFL is also something that can cause hip issues, hip flexors. So all these little small muscles can have, because they're responsible for stabilizing the hip. So quadratus femoris, TFL, glute medius, gluteus minimus, piriformis, those muscles can have an impact on the hip. So you might want to explore those. All right. Okay, so. Okay, so we're gonna do a little exercise here. You're going to find a strap or a scarf, something long enough. You're gonna find a yoga mat or something just to lie down on the floor. Okay, so go ahead and find that. You can put this video on pause while you go ahead and get those items. So get a yoga strap or a scarf long enough to hook under your feet and hold on to it. And then get a mat, or you're gonna lie on the floor somewhere comfortable. Okay, so pause that, and then we'll return. Okay, so now that you are back lying down on the floor, your back is straight on the floor. You're gonna pick one leg. You're gonna put the strap on the bottom of the feet. Your leg is straight up. You're gonna lift it up, straight up. We're gonna do stretches along the external rotator. You're gonna test the different angles. So bring your other, so let's say we'll all do the right leg just for consistency. You can do the other leg afterwards. So the left leg is straight out on the floor, lying more neutral. And then the right leg, you're gonna lift it up towards you only to feel there's a resistance. If the other leg is lifting up, you're going too far. Just bring it down a little bit. Doesn't have to go all the way. Okay, so you're gonna bring the leg towards the same side of your shoulder. So if we're doing the right side, you're gonna bring your leg, your entire leg, the lower limb, towards the right side of the shoulder. Feel for that stretch. You're gonna feel for a big stretch of the gluteus maximus. So take a moment just to feel that, feel the stretch. Some people might be, oh, I don't feel anything. Some people might feel, oh, I feel some strain happening there. Okay, so now bring the leg back to midline, back to neutral. And then now bring the leg slightly turning towards your head. Bring your leg, your entire leg. Pull that strap, okay, with your hands, pulling that leg towards your head. Feel another stretch. That is the gluteus minimus. Now a little bit deeper, very different. You might feel a little different. We take a moment just to feel that. Okay, come back to neutral position. And then now bring your leg towards your opposite shoulder. So if we're doing the right leg, bring your leg towards the opposite left side of the shoulder. Now you're stretching the piriformis. Again, if you feel a very strong tightness, hold it there. Don't go past it. So feel for the piriformis. Feel it under your glute. Okay, remember, we're feeling the right side now, right? Good. So you can feel it for a moment, and then now bring it back to neutral position. Now bring your leg towards your opposite bicep, towards your bicep, till you feel a stretch or resistance. Okay, so bring it to your left bicep area towards that direction till you feel a stretch. So that is the gemellus superior. Feel that for a moment. Good. Now slightly bring it towards the opposite elbow. Feel a different stretch now. That's the obturator internus. Now start to bring it to your opposite forearm, your leg. Still with the strap, holding onto the strap under your foot, bring it to your opposite forearm. Feel a stretch there. That's the gemellus inferior. Take a moment, feel that. It's a deeper muscle. And then bring your leg now towards your opposite wrist. That's the quadratus femoris. That's probably a little tighter because it's a hip stabilizer. Take a moment to feel that. Good. Now come back to neutral and see how you feel. You can walk around and feel if you notice a difference. Notice, go look back at the ankles. Which one did you feel that it's most tight? That's probably something you need to work on a little bit more deeper on. You can try again the left side on your own. You can come back to this part and just go through the different angles. So the different, remember the external rotator is like a fan. So if you align it by the different parts of the opposite structures here, it's going to align it with the different external rotators. So it really gives you a more specific of what muscles might be happening if there is an external rotator issue here. Here we're stretching it, right? All right, good. So before we even get into further lower, let's look at a few things with the psoas. Let's just look back at the psoas for a moment. So when the psoas is tight, we say it pulls onto the vertebrae, but also the psoas and the piriformis muscle works in opposition when we're walking. So imagine the psoas and the piriformis and the oblique internus and the iliacus works in opposition, iliacus right there, when we're walking. So psoas and piriformis works in opposition, and oblique internus and iliacus works in opposition when we're walking. So if there is kind of some stickiness, resistance when walking, look at those muscles, psoas and piriformis, and then oblique internus and iliacus. So those are some interesting points you might want to look at because they are hip flexor muscles and they're going to pull on each other. So just even what you want to think about, we looked at possibly hip issues, but even low back issues. You want to look at QL, quadratus lumborum, piriformis, and psoas. Those are the triad muscles that would be an impact that you might want to look into. Okay, now let's look lower now into the leg. So we have the gastrocnemius, that was the superficial part. Now we have the soleus, that's right underneath there. So that does not go over the knee. So it's really on the posterior side of that fibula and the tibia. Okay. So origin is at the superior 1/3 of the fibula, posterior side. So you take the head of the fibula, put one finger on the head of the fibula and one at the lateral malleolus. That is your entire length divided into 3 parts. If you divide into 3 parts, we want to take the superior 1/3. And then the tibia will take so if you take the tibia pretty much at the knee fold, and then to the medial malleolus, the ankle, that's the full length, gives you an estimate of the full length of the tibia. Divide that into 2. It's going to attach on the superior 1/2 of the tibia, also called the soleal line. So that's going to attach as the muscle right there. You can see there's the Achilles tendon, same as the gastrocnemius, there's the Achilles tendon. And that's going to attach onto the calcaneus. So this one will do purely plantar flexion. Okay, so someone that has calf issues, usually runners, if it's not the gastrocnemius, it's deeper muscles because they're using deeper muscles to stabilize the leg now. So soleus could be a possibility for that tightness that they're feeling. Okay. As you're palpating, you can palpate the gastrocnemius will probably be more widespread here. And as you go just 1 inch just further in, you can probably feel the structure of the edge of that scoliosis. So you can see here, right here would be the gastrocnemius, right on the side there. And it's more superficial. And then as you go just an inch more, you'll feel the soleus right there. You can even distinguish it by doing more plantar flexion, and then knee flexion would be more like gastrocnemius. So the gastrocnemius does do plantar flexion also, but if the problem is a knee flexion, then it's most probably gastrocnemius. But if it's plantar flexion, it could be possibly gastrocnemius or even soleus, or even deeper muscles, which we'll talk about now. Okay, underneath the soleus, now you have flexor digitorum longus. So let's divide it up into how to look at it. So flexor, it's going to do flexing the digits. So this is a posterior view. Okay, it's just showing you under the foot, but this is a posterior view. It's going to have an attachment onto the tibia right here, middle 1/3. And it's going to go underneath the medial malleolus, under the ankle, the inside of the ankle. And it's going to go into the 2nd, 3rd, 4th, and 5th distal phalange. So flexor digitorum longus. It's a long muscle. Okay, so we're going to look at the brevis later as a shorter muscle, but this is long, so it extends out longer. Right. So because it goes into the toes, it's going to do 2nd to 5th toe flexion as its main action, but it also will do an ankle inversion, bring our foot inwards because it's more on the medial side. Flexor digitorum longus on the medial side right there. And then right next to it, right down the middle, we have a tibialis posterior now. We looked at tibialis anterior, which is in the front. This is now in the back, the tibialis posterior. So origin is at the superior 1/2 of the tibia, posterior side, and the superior 1/2 of the fibula, right there, posterior side, and also anchor on that interosseous membrane. So remember, there's an interosseous membrane between the tibia and fibula. Also, it's going to come around the medial malleolus, and now it's going to insert into the tarsal bones. So so the navicular, the 1st, 2nd, and 3rd cuneiform, the cuboid bone, and also 2nd, 3rd, and 4th metatarsal base. Okay, so remember, these is under the foot plantar surface. Also here, also plantar surface is under on the bottom of the foot. So tibialis posterior, it doesn't go to the digit, so it does more of a plantar flexion or ankle inversion. It's on the inside because it's on the inside of the ankle here. Okay. So the main thing, we'll do plantar flexion or ankle inversion. So that's tibialis posterior. Usually people with shin splints, this muscle is very, very tight. Runners tend to have a very tight tibialis posterior because of that breaking, stop and go, stop and go. Okay, so that would be interesting. They might be stretching the big muscles, but it's really the deeper muscles. So by stretching this muscle is not to go as far, right? So remember, bigger movements will be bigger stretches. They have to feel a deeper structure here. So as you're palpating, you might feel the gastrocnemius, right? They're bigger, and then soleus go 1 inch further in, and then if you go 1 inch further in again, you feel the tibialis posterior, and you might feel this, wow, this muscle is very tight. That could be the problem of a lot of people with leg issue, compartment syndrome, or also shin splint issues here. And then right lateral to that, you have another one, flexor hallucis longus. Hallucis means big toe in Latin. So here you have the middle 1/3 of the fibula. It's just on the fibula on the lateral side. And again, it's going to go underneath that um, the malleolus. Here you can see there's a retinaculum connective tissue, which anchors all the tendons down, same as the wrist. Remember, there's a flexor retinaculum at the wrist. Here, there's also the connective to keep all the tendons down. So underneath, it's going to go to the first first phalange because of the hallucis. And that is going to do first toe flexion, plantar flexion slightly, because it goes across on the plantar area, the ankle area, and then ankle inversion. Okay, because it's on the inside of the ankle there. So all these three muscles, so let's look at all the layers. You have the gastrocnemius, which is the most superficial. So feel it on someone, feel on yourself, more bigger muscle, more plump on the side. As you go in a little bit, an inch, you're going to feel a different muscle. That's a little bit. And then if you go in a little bit, inch more, you'll find the tibialis posterior. So you can see the flexor hallucis longus is really right next to the tibialis posterior. And then the flexor digitorum longus right next. So pretty much the soleus covers most of these three muscles. So layer 1, layer 2. So layer 1, gastrocnemius, layer 2, soleus, and all these three are on the same layer. So tibialis posterior right down the middle, hallucis on the lateral aspect, and the flexor digitorum on the medial aspect right there. So here's another image of just all that layering. Soleus right there. You see here the gastrocnemius is cut, so you can see right under. And then we have the tibialis posterior, flexor digitorum longus, flexor hallucis longus. Okay, so really be curious, feel the fiber orientation, feel the separations of that. That's how you're going to learn. That's how you're going to feel for more detailed the structures. And here, excuse me. And here I was talking about all the different tendons that is underneath the ankle. So tibialis posterior is first, and then flexor digitorum longus right under that, and then flexor hallucis longus. So a way to even learn it. Think about Tom, Dick, and Harry. So Tom, tibialis posterior, Dick, flexor digitorum longus, and Harry would be flexor hallucis longus. So it lines up right underneath there. And here you can see that's the flexor retinaculum that keeps those tendons in place. Okay, let's move on towards the front a little bit, more lateral, anterior lateral. So we have the tibialis anterior right in the front right there. Now right next to it, we have the extensor digitorum longus. So again, look at the digitorum. So anything within extension now, so dorsiflexion, this is on the dorsal part. So extensor digitorum longus, it's going to be on the fibula, superior 1/2, more on the anterior surface, and then anchors onto the interosseous membrane. So look at the muscle belly, and then you can see tendon, tendon, tendon. There's a retinaculum here. There's also retinaculum to keep the tendons in place. And then it goes all, these are, look at this, all tendon going to the second, third, fourth, and fifth distal and middle phalanges. So if you wiggle your toes, bring your toes into extension. Okay. You can feel that muscle pop up. If you're going to do more a full dorsiflexion, do a full dorsiflexion, the tibialis anterior is going to pop up. Okay, this one will also do dorsiflexion as a synergist, but its main thing is going to be palpate that on yourself, on someone, feel the difference. Dorsiflexion, you're most probably you'll have the tibialis anterior pop up, and if you just wiggle your toes, it's going to be more the extensor digitorum that's going to pop up, but it will do dorsiflexion and ankle eversion. So it's more on the lateral part, so we'll do an eversion there. Okay, so that is extensor digitorum longus. And then you have extensor hallucis longus. Remember, hallucis means big toe. So it's going to have an attachment on the fibula, middle 1/3 right there, anterior part surface, and onto that interosseous membrane. And then it's going to look at this extensor retinaculum, again, keeping that tendon down, going to the first big toe, distal phalange. And then if we bring the first toe into extension, that's going to activate that muscle. So it also has a dorsiflexion ankle inversion as synergist, but its main thing will be extensor hallucis longus. So test it out. Do a big dorsiflexion, you'll have tibialis anterior pop up, wiggle all your toes into extension, second to fifth more specifically, you'll have the extensor digitorum longus. And if you just bring your big toe now, this smaller muscle will pop up so you can feel that. Okay. All right, so you have the tibialis anterior, extensor digitorum longus, and extensor hallucis. All these are superficial. They're all on the same layer. Okay. So you can see that the anterior, there are more superficial muscles as the posterior part has deeper layers there. Okay. You can see here, it's all on the same layer. Try the test, plantar dorsiflexion, tibialis anterior, wiggle your toes, into toe extension, you'll feel extensor digitorum, and then toe flexion with extensor hallucis longus. Yeah, if you haven't done any of the coloring, I suggest going to the coloring book and really coloring it, connecting dots. That really helps with that visualization, and then start to palpate. Right? The more you can visualize, the more you can feel more as you massage. Because if not, you're just going through the superficial emotion. You really want to feel the structures, the division, the structures, what's causing what. All right, so here just shows you the different tendons, how they're lined up. So tibialis anterior, extensor digitorum longus, hallucis, and then here the fibularis longus, right behind the ankle, and then the brevis, the shorter one right there. Okay, so here's the brevis, fibularis brevis. We know the longest goes on the lateral end, on the head of the fibula, going down into the first cuneiform and first the first cuneiform and the metacarpal bones, first base of that. And then right underneath there, you'll have the brevis. So the brevis will attach onto the inferior 2/3 of that fibula, lateral side, more on the lateral end. And then that's going to attach onto the 5th metatarsal base right there. So if you do an plantar flexion, ankle eversion, see if you can feel that muscle pop up right under there. All right, so that is the lateral part. So the fibularis longus is superficial and the brevis is under. Now let's look at the foot muscles underneath the plantar part of the foot. So it's based on its action, abductor hallucis, right? It's going to do more abduction of the big toe, bringing the big toe outwards. So all these three has attachment on the calcaneus. The calcaneus, the base, actually on a tuberosity, there's a bump right there. So the abductor hallucis, more on the medial part. And it's going to go into the first proximal phalange right there, more in the medial aspect on the outside there. So if you take your big toe, bring it outwards, you're going to feel a muscle right there. That's the abductor hallucis. And then let's go on the pinky side, abductor digiti minimi, bringing the little toe outwards into abduction. So into the calcaneus tuberosity on the lateral part, and then to the 5th proximal phalange right there, bringing the big toe outwards. And then right in the middle, you'll have the flexor digitorum brevis. We already looked at the flexor digitorum longus. This is the brevis, the shorter one. So that's going to flex the toes, second, third, fourth, and fifth. So we're going to have an origin at the calcaneus, more on the back side right here, the plantar side. And then it's going to go to second, third, fourth, and fifth on the middle phalange, the middle phalange right there. Okay, on the plantar side. So this is all on the plantar, on the bottom of the foot. So people with plantar fasciitis, flat feet, all that issues with the feet, runners that have feet issues, look at these muscles, follow that, follow the muscles. The more you can be more precise, the more you can help your clients more specifically. If they have any kind of heel issues, you can look at all the muscles that can be pulling on all these muscles. Okay, so because of that interosseous membrane, it's divided into compartments. We already look at the compartments of the forearms. This is also the legs are separated into compartments. So if you have people that coming in with compartment syndrome that are diagnosed with compartment syndrome, first you want to ask them, is that the leg or the forearm? So if there's an anterior compartment syndrome, anterior compartment is the tibialis anterior, extensor hallucis longus, extensor digitorum longus, fibula tertius. We didn't look at that, but it's part of that compartment. So remember, all these are the superficial of the anterior part. And then the lateral compartment, you have the longus, and the brevis is underneath the longus. And then you have the superficial posterior compartment. You have the gastrocnemius, underneath is the soleus, and then the plantaris. We didn't look at that, but that's part of the superior posterior compartment. And then you have the deep ones. We have the tibialis posterior, hallucis, flexor hallucis longus, flexor digitorum longus. So these are all in the same layer, right? So you have the gastrocnemius, the soleus, and then you have these three muscles on the same layer. So you also have the popliteus. We haven't looked at that, but that's part of the deep posterior compartment. Okay, so it's just separated by different, even the anterior or the posterior or the lateral compartments. So you can see how it's divided into sections, right there. Anterior compartment, and then you have the deep posterior compartment, you have the superior posterior compartment, and then you have the lateral compartment. Okay, so compartment syndrome usually happens when there's any kind of fracture, any kind of accident that is causing areas in this to close up, to tighten up. Okay, so let's look at the lower limb, the nerve flow innervation, lumbar plexus, sacral plexus, vascularization, femoral vein, diaphragm. Okay, so we continue into our treatment plan. Femoral vein, just an image of how all the lower limb is going through, all the deoxygenated blood is going through the vein, through the femoral vein right here in between the groin area under the inguinal ligament. So imagine the inguinal ligament is there. It's going to go back up into the common femoral vein, back into that diaphragm area, back towards the heart. And then all the red here is oxygen blood feeding into, these are arteries feeding back into the leg. Okay, so it's important to clear that if there's any kind of inflammation, right, we want to make sure that is cleared proximal to it. We don't want to create more inflammation. So let's say there's inflammation in the knee, we want to work above it. We don't want to work below. We don't want to work distal. We don't want to create more inflammation. So the femoral vein, just to give you a visualization of what we're doing when you're doing those flushing techniques. This is what you're doing. You're flushing all that deoxygenated blood through that pathway back towards the heart. So here, just under that diaphragm, give you another visualization as you bring more of that deoxygenated blood, you bring through the diaphragm. This is from a bottom view right here, through the vena cava, inferior vena cava, and then goes back to the heart. And here you can see aorta good blood. Blood is going to go through there, through the abdominals, and then it's going to go through arteries through the lower limb. Okay, so it's important to work the diaphragm whenever we work the lower limb area. And then here we have the plexuses, L1, L4, abdominals, lower limbs, genitals, and then sacral plexus, the glutes, lower limb, even the sciatic nerve, something to consider. Some common injuries we might see in the hip, sciatic nerve, any kind of pelvic imbalances, a lot of hip flexor issues, especially people that sit a lot, hip external rotator issues, that can be an issue, hip stabilizing issues because due to hip replacement. So we want to look at those different hip stabilizer muscles we talked about. Any kind of knee issues, could be meniscus issues, shin splints. We see that in a lot of runners. Remember, the tibialis posterior is a huge muscle that can cause that. Any kind of leg compartment syndrome. So depending on where the issue is, that can be due to a fracture or any kind of accident towards the legs. Circulation issues, varicose veins, nerve impingements all along that nerve path, plantar fasciitis, that could be flat feet, runners happens a lot, that impact of the bottom of feet, SI issues, sacroiliac hip joint issues, not the hip, but more the sacroiliac in the back where the lumbar and sacrum is, that can have an issue there. Coccyx issues, any falls on the lower, on the tailbone, ankle sprains, that can sprain the ligaments that support the ankle, post hernia surgery that can create any imbalance of the hip, C-section scar tissue can affect the hip also, and any kind of posture imbalances, pelvic floor issues also. Okay, so let's look at a treatment plan. I put an example as the right soleus here. So the right soleus, the affected is plantar flexion. We always want to look at what action is associated. So let's, for example, the problem is the plantar flexion. So you want to consider the left soleus, of course, because it's the opposite side, it's compensating. The right tibialis anterior, because it does dorsiflexion. Okay, so we want to consider there's a big muscle there. So we want to look at the bigger muscles first. I know that there are other muscles that might be doing it, but let's look at the bigger muscles to begin with. And then synergist would be the right gastrocnemius, because the gastrocnemius also does plantar flexion. So we don't want to really look at the deeper muscles at this point because the soleus is more in the second level. So the tibialis posterior could be something we want to look later on if that's not the problem, but we want to look at anything right above it. Okay, global, local, global, so more posterior leg generally, and then go into the soleus and then back out to reintegrate the tissue. Superficial, deep superficial, so look at gastrocnemius and then look at the soleus and then come back to the gastrocnemius because it might be guarding, muscle guarding. And then innervation, lumbar plexus, look at the latissimus dorsi. So, I find that one of the biggest mistakes some students make is they look at lumbar plexus and they look at latissimus dorsi, longissimus, QL, multifidi, and rotators. I'm like, oh, look at all these muscles. You have to think practically. The purpose of the innervation is just to clear the pathway. You have 5 minutes to do that. You won't have time to go through those layers within 5 minutes. So be logically, think of the logic. Are you able to achieve that within the time frame? So for 5 minutes, let's just open the pathway, open the latissimus dorsi, because the problem is not the spine, because the rotators and the multifida are more stabilization of the spine. It's not going to have a huge impact on the lumbar plexus. So think smartly, more effectively within the time frame. What do I need to achieve? If not, you just get lost into that. Right? Sometimes I see a treatment plan, just 5-6 muscles layers within 5 minutes. You can't achieve that. Okay, neovascularization, same thing. You want to look at something more superficial. You would just clear the pathway, rectus abdominis. That's clearing the pathway there. I mean, if you find more tension, you can address that. and say, okay, maybe in the next session, something is happening there. Make a note of it. It could be something else that's going on. Okay, so we put into 1 hour session. So these treatment plans really helps us to stay focused on what we're trying to achieve. So the problem is right soleus, 5 minutes on the rectus abdominis, vascularization, 5 minutes. So think about techniques more superficial, more effleurage, just opening up the pathway. And then 10 minutes into the right tibialis anterior, the antagonist muscle. Since most of the work is going to be in the back posterior, we want to do all the work that is on the anterior part. So on the facing up first, so that vascularization, antagonist. And then we flip them over, we do the opposite side, left gastrocnemius and soleus because it's superficial, opposite, superficial, deep superficial. So we just want to clear that out because it's more superficial. And then the soleus to see what to do that comparison on the opposite side. Then we go on the right side, do more global local work, opening up, warming it up, spending that time there from that global aspect, and then zoom into the superficial, deep superficial. That's also a synergist. So you can spend about 5-10 minutes, depending on the time you have, feeling how the gastrocnemius is. And then your affected area, right soleus. Okay, so you're really building your session according to what might be pulling the right soleus off center for whatever reason there. Okay. All right, so that is for the module 8. So go ahead and review the theory in the notes, the bony landmarks, the actions, the muscles, origin, insertions. Look at the muscle chart that I gave you guys. These are the coloring pages. I do recommend the more you can visualize it, the better you can feel it on the body. So do the coloring, only coloring the topics, the structures that we covered in class. Fill in the muscle charts of the antagonist synergist. That's going to help you also to make links. So all these homeworks I'm giving you is to help you build your confidence, and so you can look at the body quickly, because when you start to test, you have to be able to react. So the more you do these exercises, you're actually training your brain to look at the body in different ways. Okay, so from a visual aspect, the muscle charts is really to make links of the action, the biomechanics, and then make sure you do make time for the palpate all those landmarks on the just do it theoretically. We need to feel it on the body. And of course, the treatment plans, the more you do the treatment plans, the more it becomes more natural. Pick a muscle out of a hat and just do a treatment plan, see how fast it takes you. All right. So that is it for the modules for the level 1. And good luck on all the different palpation exercises that you do and all your techniques. And I hope to see you soon.